Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Hi, and welcome back to Unraveled. I'm David Kaufman, and I'm here with
Eileen Ruhoy. Hello.
Today we're going to talk about mast cell activation syndrome in more detail, talk about how to think about it, get a history for it, diagnose it or confirm the diagnosis, and how to treat it, manage it. Okay?
Where to start?
Yes.
It's such a huge topic. And we were just mentioning how we probably say mast cell on every episode.
Right.
So I think it's sort of time for a larger conversation about mast cell.
Exactly. We got to go into some detail here.
I don't think I see a patient that doesn't have mast cell activity. Some activity,
well,
right?
I think that's true most of the time. But, you know, I did that chart review, which I come back to all the time, and 80% of my patients with an MECFS criteria-driven diagnosis have had MCAS in that month of patients.
Right.
And I stand by that. That's what I keep seeing over
and it waxes and wanes, right?
Yeah.
So I think that's one thing that's not understood all that well, which is that you have a diagnosis of MCAS. It doesn't mean that you are in a flare of MCAS every single day, right? So it goes up and down.
Right. So let's start with history and one of my endlessly repeated expressions, index of suspicion. Okay.
Oh boy, it's a big topic.
I think,
let me take a sip of my purple carrot juice.
Okay. I think when we see patients, any complex patient, and probably, you know, I would say in general, seeing patients, one needs to go into it with a relatively high index of suspicion that this patient might have MCAS. So what does that mean? It means that in taking a history, it needs to be detailed and comprehensive, obviously, words I keep saying, and most importantly, start from the beginning. So I'm sure you have the same experience, and I know many of the other people in our mastermind listserv talk about it all the time. The number of times I've met a patient who says, "Doc, I was fine until I was 23, I had mono, and nothing's been the same since. And for the last 12 years, I've been to 14 doctors, et cetera, et cetera." And then you take a history, and the patient will say, yeah, my mom's pregnancy and delivery was fine. From 0 to 2, I just had, some little bit of food problems. They told me I was, quote, colicky. From 2 to 5, I seemed to have some trouble with food, and I would get nauseous and sometimes diarrhea, and every once in a while a rash. From 5 to 12, I had rashes all the time and frequent sinus infections and frequent upper respiratory infections, but I was fine. Didn't interfere with school. Parents said I was fine, et cetera, et cetera. Those, to me, in the subsequent context of hearing clear evidence, which we'll get to, that is mast cell activation syndrome. Mm-hmm. It's just, it's quiet. It's mild. It's just there as background noise.
And it's not necessarily a disease or a pathologic necessarily. I just think it's very often under considered in all these very common diagnoses, frankly, especially in pediatrics, especially in pediatric neurology. I think about all those kids that I had seen when I was doing pediatric neurology at a children's hospital, how many, very common complaints and ailments were referred to neurology that I now realize, of course, there was an underlying mast cell activation concern, and it would have changed my treatment options is all I'm saying. Right. I think it, wouldn't change the course of whatever the disease was necessarily, other than it could have helped minimize the symptoms that were going on.
And I want to be clear. I'm not saying that the doctors misdiagnosed this child or kid or teenager, or that they were wrong, or that they weren't paying attention. It's a very reasonable statement to say, yeah, you get infections when you're a kid, et cetera, et cetera. But when that same kid turns into a 22-year-old who now has mono and chronic fatigue syndrome, and they tell you this, and as an adult, they now have food limitations and everything else, which we'll get to, you realize that prior history is setting the stage, that the person had a predisposition to twitchy mast cells.
Right.
But they were kicked into high gear by that infection. And that changes the presentation.
Exactly. And we talk about that with connective tissue as well. You're born flexible, and then you get an infection and things go awry. Right. But it's, I even think back to when, even in med school, when you learn about atopy, right? What is it? Eczema, allergies, asthma. you never hear about the mast cells.
Right. Right.
I mean, you learn a little bit about histamine, of course, which was, I think, the first mediator identified that
Right.
came out of mast cells. But when you think about the hundreds of mediators, I mean, you don't learn about the mast cell role in atopy, which is shocking to me now that I know what I know.
And just to further clarify it, okay? I'm also not saying, neither of us are saying that if you have allergies as a child, it doesn't mean you have mast cell activation syndrome. It does mean that you may be at risk down the road when the proper trigger kicks in and amplifies it and magnifies it.
Exactly.
And that's generally been my experience, that it's some sort of infection that kicks it into high gear. It can be trauma, it can be other things, but most often it's infection.
And I think that's an important point. I think these are risk factors that we are recognizing now, because it's sort of like we're doing the puzzle backwards, right? We sort of see the end picture, and we're sort of, going backwards and recognizing that there were risk factors all along throughout their lives. And I think the more we understand that and the more we embrace that, the more we can better identify those risk factors early on and take a more preventative approach, right? Than trying to sort of now correct and be curative and fix a problem. So and that's ultimately a goal, I think, of every doctor, right? You want to be more preventative, and if not preventative, then maintenance-wise. But you sort of don't want to be the patient to be in a position where now you have to try to cure them, because that's, as we know, is a harder road.
And part of the issue here, obviously, is that MCAS, mast cell activation syndrome, is not well appreciated by most of mainstream medicine, or even non-mainstream medicine for that matter. And so what it is diagnosed as is allergies. And if you think about the numbers of people who say, oh, it's my allergies, and they're popping Claritin and Zyrtec every day, that's a big signal, okay? And it's okay if it just stays that way. But it's when it changes and everybody scratches their head and doesn't understand it, that's when the whole ball game has changed.
Right.
Okay, so history, as usual.
I mean, you can go by organ system in a history and pick up mast cell activation in each organ system.
Right.
It's amazing how, because, I guess the mast cells are just so ubiquitous. So it does sort of make sense to some extent. But
they're ubiquitous, and they have, these 1,000 mediators they release. And, they are most dense in environmental interfaces, skin, arms, mucous membranes, gastrointestinal tract, but they're also all around nerves and blood vessels. And then when they release their mediators, those mediators hop into the blood and circulate, and now you have mediators in your brain and your gut and in your toes. It's everywhere.
And it just changed treatment. I mean, if you think about even hollow organs and other organ tissues, I mean, the mast cells reside there as well. So, even things like interstitial cystitis, for example, which, majority of our patients have, has been now associated with mast cell activation syndrome. So I think it changes treatment options, and I think that's really important, because as we've talked about in previous episodes, treatment of mast cell activation syndrome can start off fairly easy, very benign, and then go from there. But it can give patients a lot of relief very quickly early on, fairly easily. And so why not do that if you can?
Right. Relief and validation.
Yeah, absolutely.
So before we get into treatment, so we're saying history, and then you have this complex illness patient in front of you. And I think when you and I use the word complex, in some way we're trying to, what's the word I want to use? We're trying to make it sound better than what we initially think, which is, oh my God, this difficult, crazy patient with these crazy problems, how am I going to figure this out? That's what's complex.
Right.
Okay. And
it's complicated. Maybe that's a better word.
It generally means multi-organ system, multi-inflammatory.
That's exactly what it is.
Which is the definition of mast cell activation syndrome.
Yes.
Okay. So you take the history, and if you're lucky, in quotes, the patient will say, every time I have these 14 foods, I get hives and a fast heart rate and brain fog. Diagnosis is done, as far as I'm concerned, regardless of confirmatory labs. Okay. Same thing with if they say, every time I go out in the sun, I get these crazy rashes, or every time I take a shower, I get hives, or every time I walk into Nordstrom through that darn perfume section, I suddenly get tachycardia and brain fog. That's mast cell activation syndrome. Okay. It's a mast cell trigger response to food, fragrance, pressure, everything.
Yeah,
okay, that's the thing that's so
everything.
crazy about
Yeah.
it. You know?
I mean, mechanical compression
Exactly.
does invoke the mast cell rule.
Exactly.
Yeah,
Exactly.
absolutely. It's everything.
Okay.
Yeah.
So
And when you're just listing all that, I'm like, oh, that all happens to me.
so the point I want to really make strongly is, to me, MCAS is a clinical diagnosis made by the physician with the patient based on this history, preferably a long history that's carefully elicited, and hopefully confirmed by laboratory workup.
Hopefully.
Because the laboratory workup is very difficult. The processing of the blood specimens it's not complicated, but it's very time dependent. Theoretically, the blood should be drawn into a chilled tube, spun in a chilled centrifuge, immediately aliquoted, which means pull off some serum or plasma, immediately put into the carrier tubes, immediately frozen and kept completely frozen until it gets to the lab.
Right.
And often, at least for one specimen, it gets to the main LabCorp or Quest lab and has to be shipped to another lab in Southern California. How many times do you think that gets done the right way, even in a person's own lab? All right. I used to do it in my office when I had when I was in Mountain View in California, and I had a great MA. She did it perfectly. The only thing we didn't do was a refrigerated centrifuge because it's very expensive, and we often didn't get positives back in patients, I was sure. Okay, so I want to emphasize that a positive is diagnostic, a negative doesn't rule it out.
Right. I always say you can rule it in with abnormal labs. You can't rule it out with normal labs. And the other thing is these labs are often a point in time.
Right.
So you're not going to always find elevated, even if it's done technically correct, you're not going to always find elevated labs. And just speaking, by the way, there's a whole list of labs. So we're not talking about just the histamine level.
Yeah, let's go through them.
Okay.
So histamine, the obvious one, that's the major mediator, a major mediator released. That's one that has to be frozen.
Right.
Chromogranin A. The nice thing about chromogranin A is it doesn't need to be frozen. And I often find of all the things we're going to mention, that's the one that comes back positive.
Right. And it's also the one that scares a lot of patients because then they Google it.
Exactly. So full disclosure, everybody, listen up, okay? When your chromogranin A is elevated, 999 times out of 1,000 has nothing to do with what you just read about on Google, which is neuroendocrine tumors. This is not a tumor marker in you. It is a marker of mast cell activation syndrome. And I now tell every patient before I send them for their labs because it's very upsetting. Yeah. Okay, so histamine, chromogranin A, tryptase, although I will fully disclose also, I've almost completely stopped drawing tryptase.
Really?
It's never elevated, rarely elevated, okay? And all it does is throw everyone off because they say, oh, you have a normal tryptase, you don't have mast cell activation syndrome. Because in mainstream medicine, the going consensus one, as Larry Afrin would say, definition, it requires, I forget exactly, a 20% elevation of tryptase. Mast cell activation syndrome patients almost never have that elevation unless they have that genetic abnormality, which I guess we'll have to address in a second.
Right.
Okay.
Right. Which is a problem, of course, because as you just sort of mentioned, most hospitals and medical centers and medical offices, if you have a normal tryptase, they will just flat out say you don't have mast cell activation.
Your doctor's crazy, you don't have mast cell activation.
Right. Okay. Which is so ridiculous to use that as the one marker to decide or not.
It's just crazy.
Yeah.
So tryptase. And then a test that I love, but it's very hard to get it properly processed, is prostaglandin D, as in David 2, prostaglandin D2. That's the one that gets sent to a lab in Southern California. That is almost exclusively a molecule released only by mast cells. If that's elevated, diagnosis done. I don't run heparin, which is another mediator, because I can't find a lab where I can get it done accurately. It's very, very difficult. I always start and only start with the blood tests. I don't start with urine tests, because if I can get a positive in the blood, why torture the patient with the urine collection, which is even more complicated. They got to collect 24-hour urine. The jug has to be kept in the fridge.
Right.
When they collect their current new urine sample, they have to cool it before they add it to the jug. I mean, it's just ridiculous. Right. And then, of course, you bring this jug to the lab. You plop it down on the counter with the technologist. He or she looks at it and says, "What's that?" And you say, "It's a urine specimen, 24-hour urine. You have to keep it cold." And they say, "Yeah, sure." And they just put it in the back until they have time, which is understandable because they have 14 people waiting for their blood draws.
Yeah.
Okay. So I only do urine if absolutely necessary.
Okay.
I do repeat the blood.
Okay.
And often find positives the second time or the third time. And I do consider a borderline elevation as relevant. So if a histamine greater than 1 is abnormal and I get a 0.9, I suspect that's abnormal. Conversely, if I get maybe not conversely, if I get if I get a 1.8, I treat that as probably more like a 10. Meaning it was 10 when the needle was in the arm. Mm-hmm. By the time it got into the freezer, it had degraded down to a 2. And then from freezer to lab to processing again, it's gone down to 1.8.
Okay. And that's all you test for mast cell?
Those labs?
Yeah.
Well, the urines and the bloods. Well, and CD117. You can talk about that.
Well, well, but what about, like, for example, like I do, like MMP9?
I don't usually do that.
No? Because that's such an important protease to me because it breaks down connective tissue.
Well, yeah, but is it exclusively released by mast cells?
No, not exclusively, but, you know, in a hypermobility patient
right.
who I suspect mast cell activation, I want to know if there's an elevation.
That's a good point.
And I feel like it's a supportive lab.
Yeah.
And then the other thing that I often check is mannose binding lectin, which is not also exclusively mast cells, but you know, there's lots of literature actually regarding deficiency of mannose binding lectin and mast cells, and even neuropsychiatric symptoms.
Right. I check it because it's also a marker for immune deficiency.
Right. Exactly.
Yeah.
And then I also add antiphospholipid antibody panel.
I do that on every patient anyhow.
Okay.
Yeah.
And then the early Sjogren's panel.
On every patient. But I don't take positives there to mean they have mast cell activation syndrome.
See, with the early Sjogren's, though,
that diagnosis.
Right, I see what you're saying. So this is more of a confirmation. I sort of look at the entire picture of, I guess is what I'm doing, without realizing that's what I was doing. Because I'm always presuming that mast cell activation syndrome exists.
Let me make it more clear than what I'm saying. Because I agree with you, all right?
Yeah.
So I have a new patient, okay? What I order, and you know, the poor patients are not happy and the phlebotomists hate me. What I order is roughly 30 tubes of blood, okay? And it includes all these mast cell tests, antiphospholipid syndrome, early Sjogren's, a full viral panel, usually now with PCR and serology, which means antibodies, all the sort of, quote, routine, significant other autoantibody testing, usually a nutrient profile for vitamin levels. So, yes, I do all of that.
Yeah.
But
so I guess we're deciphering between supportive labs and more confirmatory labs.
Right,
Got it.
Right.
That's interesting to me because I sort of see it as one big picture, and that's what I'm trying to confirm.
Right. So I'm doing both, and like you were both saying here, and I really think we have to emphasize this: negative mast cell laboratory testing, as far as I'm concerned, in no way rules out the diagnosis of mast cell. Not everybody agrees with that, but I am absolutely convinced of it. Okay. The further convincing evidence is that in that first visit, when I order all the blood and I think the patient has mast cell, and I send them home on Zyrtec and Pepsid, and they message me 2 weeks later and said, I don't know what you did, but my brain fog's better and it only cost 15 cents. Right? That's, to me, further confirmation.
Right. And I think, I mean, did you once say that sometimes you don't even you just start them on treatment?
Yes,
and,
that's what I'm saying.
You say, say that.
No. Yeah, if I have a reasonable suspicion.
So before even labs, you're saying?
Yes, before even labs. Right.
But you don't have them take those drugs before lab, right? So
you can take the mediator blockers, and they will not affect the labs. You can take histamine 1 receptor blockers, or the over-the-counter antihistamines, Claritin, Benadryl, Zyrtec, Allegra, okay, and Zyzal. They will not affect the blood work because the blood work is looking at the histamine levels, not the receptor blockade. Right. You're not changing the degranulation level.
Right. But, I mean, do we know that for sure? Because, you know, I have a very high respect for physiology, and I always find that when receptors don't have what they want, it does change the amount that's released because there's no feedback. Yeah,
but this is pathological release, so the feedback isn't helping. It might help for me if I don't have mast cell activation.
Right.
I mean, this is what I kind of have read and been taught.
Okay. No, that makes sense to me.
I know Larry Afrin says this. I mean, feels this way.
Right.
The one catch, though, is, according to Larry, Mast cells have histamine receptors on their membrane as well.
Right.
And therefore, the histamine 1 receptor blockers may decrease degranulation.
Right.
But which would speak to what you're saying
Exactly. Yeah.
But he's, as far as I know, insistent that it doesn't affect the
Okay.
lab results.
I always just sort of tell them not to take any antihistamines prior to the blood draw because I feel like it's just safer and cleaner.
You're probably right.
And even when we do autonomic testing, I tell them to hold off on their antihistamines.
Right. So they absolutely should hold off on things like ibuprofen and aspirin because those can block degranulation. All the mast cell stabilizers, which we'll get to in a minute, and stuff like that. It's a good point. Maybe I should wait.
Yeah. I just think then it poses no question, right?
Yeah.
So, because I think that there were some studies done on many years ago on like proton pump inhibitors.
Right.
I remember reading about how if you're just sort of blocking the pump, basically, the release of the hydrogen ions is actually less because of some very intricate feedback loop.
Yeah. I guess my approach is I'm usually pretty suspicious.
Yeah.
And if they respond, I'm done. I mean, to me, that makes the diagnosis.
Exactly.
And the negative labs don't really change my opinion that much.
I agree.
I like to get them because it's confirmatory.
Right. It's always nice when they're positive, when they're abnormal labs, because then you can objectively say to the patient, this is clearly what's happening and I could prove it now. But I think at this point, I just presume it and I treat it regardless of what the labs show, but I always get the labs anyway.
Good point. I probably should wait.
So they come back positive and then we treat.
Right. But before we do that, one other test. So if I have a patient who's had an endoscopy in the recent
tissue.
5 to 7 years or something like that, and they've had a biopsy as part of that endoscopy, I will try to get that information so I can request special staining. It's called CD117 staining, which is specific to mast cells. They never do it in the laboratory, the path lab routinely. It's never done. They almost always argue. They don't want to do it when you request it. You want to get a CD117 stain of the sample and have the pathologist count the number of mast cells per high power field. So they don't want to do it, and then they don't want to do the counting. And what I get back usually is, yeah, we did it, and they don't say that, but that's the message. We did it, and there's
40
random. No, they don't even count. There's just random mast cells, no aggregation, no sign of mastocytosis.
Sometimes they count.
And then I go back and I say, please count high power field. And then they say, oh yeah, okay, so it's 48 per high power field. What does that mean? It means the person has MCAS.
Yeah.
Anything over 20 is considered positive.
I think tissue samples are key.
They're the best.
I love tissue samples. So you're right. So endoscopies, even if they've had them like a year ago,
I'm not casting aspersions on your husband who's a pathologist.
He regularly does them.
I know
because he knows of the work that I do. But honestly, like if you can get tissue samples and do the CD117 and then the mast cell count, I've had patients who've had thymus resections for hyperthymomas and thymic dysplasia and stuff like that. And I've actually gone back and asked the pathologist to do mast cell staining. It's only happened like a handful of times, and they've done it, and we found mast cells in the thymus. So,
other tissues too.
and of course anything of the gastrointestinal and skin biopsies, you can check for mast cells. So I would argue that any tissue, but obviously it's going to be hard if someone's getting like a resection of their liver to beg a pathologist to do mast cells when that's not the indication.
And we're talking endoscopies that can be routine, like if it's a surveillance colonoscopy.
Oh yeah, absolutely.
If they saw something in biopsy,
they always biopsy it, even under surveillance.
Right.
They biopsy regardless of whether they see a polyp or not. They take tissue samples at every scope.
So the tissue's there, and it's there. It's just definitive.
Yeah, I completely agree. And I think tissue is ideal, as with everything, right? Any pathologist will tell you that. Getting a tissue sample is really the best. Right. I mean, even when you compare things radiographically, and I realize mast cells can't be seen on imaging, but just in general, when you compare what you can see histologically under a microscope compared to what you can see with the resolution we have available on imaging, there's really no comparison. So which is why biopsies are so important for obviously identifying certain cancers and also staging certain cancers. So I think it's the same with mast cells. I think that, if you can get a tissue sample, and I'm sort of leaning towards in that direction, like whatever, if there's a prominent organ involvement that I think there's a mast cell component to, if I can figure out how either I can biopsy it if it's more surface, or if it's a visceral organ, for example, if I can get their specialist to do a biopsy for mast cell concerns, and I try to push for it these days.
Do you send people for endoscopy in order to get mast cell biopsies?
All the time.
Yeah, I don't.
If they have any gut problem,
Yeah.
I tell them to just to get a scope, right? Because
But what if they don't? What if they don't have GI symptoms that would normally, in your pre-mast cell life as a doctor, you know, no GI symptoms, so you wouldn't normally order an endoscopy. Would you still order it for mast cell?
I
'Cause
would.
I don't.
I would.
Yeah.
Yeah. First of all, the majority of patients have some level of, either reflux or gastritis or
Yeah.
constipation or postprandial or food concerns or gas and distension. I mean, they all have some level of a gut symptom. Or if I look at their age, I say, time for screening.
Well, that's different. I mean, again, that's different.
Well, I mean, but not. I mean, if I find a way to get them a scope, I find a reason that I can order a scope for them.
Yeah. I have not wrapped my head around the idea of ordering endoscopy just to get a mast cell stain.
I think if it's severe enough where the patient is having severe discomfort and it's really impacting their life. Yeah.
If there's significant GI symptoms that, regardless of mast cell issues, warrant an endoscopy, of course I would do that.
Right. But there isn't always a gastroenterologist in their world, or at least one that's on board. And so I push for the scope.
Yeah. Okay, so patient has negative labs,
but
negative
positive
CD117, and positive history and positive symptoms. Okay? What do we do for this poor person?
We treat. We validate that they have mast cell activation disorder, and I always give them the reasons why I believe so, even though they have all this normal lab work. And I go over all of their symptoms and how the mast cells are contributing to the symptom, and how it's causing the symptom. And sometimes I even try to identify the appropriate mediator that's associated, because there are a lot of mediators. Of course, there's all the cytokines and chemokines and chimases and so on. But and then I just treat. And I know we've touched upon this in other episodes, because I remember saying this, but I really like the mast cell stabilizers because they release, they decrease the release of a little bit of everything, right? So I've said that before, so I know you've heard. I know you've all heard this before.
Let me pose a rhetorical question, probably. Okay. In general, in medicine and in mast cell activation syndrome treatment, we start with what I'll call for the moment tier 1 treatment, okay, which is over-the-counter histamine 1 receptor blockers and histamine 2 receptor blockers. So the antihistamines I mentioned, and then famotidine, Pepsid. Okay, we used to use
I like
Zantac.
famotidine a lot.
That's gone. And what?
I like famotidine a lot.
Right. Okay, but that's a histamine 2 receptor blocker. The key point being they are blocking something that's already been released.
Right.
Okay, and then patient responds, but not enough. And you go to tier 2, which is the mast cell stabilizers. I don't know why we don't start with tier 2.
I don't either.
And
I do.
I more and more do, because like you just said, what's the point of slamming the door after the horse is out of the barn? We want to keep that door slammed. So we go to the mast cell stabilizers.
Yeah.
Which
and my favorite is cromolyn.
Right.
Frankly, there's a couple of others that I was reading about actually last week that I never even heard of. I'm not even sure they're available. I don't remember the names, so don't ask me. But they don't have brand names yet. They were all generic long names. But there's a lot more mast cell stabilizers than I knew existed, and I want to learn more about them. But I very regularly use cromolyn. I very regularly use ketotophin. I very often will say aspirin. We've talked about the benzodiazepines, which I'm a big fan of.
Right.
So
let's go through each one in a little detail. Okay. So cromolyn. I agree. I like cromolyn.
I love cromolyn. I wish it wasn't so hard for patients to take.
Exactly. So I was going to say, first I was going to say I love it, but it doesn't work for everybody.
Right.
For those in whom it works, it is a total game changer drug. Okay. Total.
Yeah.
Unfortunately, it doesn't work for everybody. The problems with it are, this is America, it is outrageously expensive, the prescription form. I think it's like $2,000 for a month supply in the doses we use. So it routinely is rejected. It's total nightmare. It comes in these ridiculous 5 ml plastic vials like that candy that you used to sell as a kid in the plastic thingies. You know what I'm talking about? So each vial is 100 milligrams, and the typical dose is 300 or 400 milligrams 4 times a day. So basically, this poor patient has to go outside during the day with a shoebox filled with these vials. It's a nightmare.
It is a nightmare. And if they have to travel somewhere, my God.
Travel, it's like a joke. Okay. However, you can get it compounded, and this still being America, The cost of compounding is often less than the copay on your insured version of commercial cromolyn. Okay, and the beauty of compounding is it's a capsule, and you just pop your capsule. So it's great.
I don't compound enough, I will say, and I should. I should think about that more often.
Yeah, it's great.
I guess I'm just always hopeful that I just, electronically prescribe to their pharmacy and their insurance will cover it. And then they can start it, and if it works, then great, then I titrate upwards.
Right.
But I have to start compounding it more. You're right.
So two important takeaways or pearls about cromolyn. The first is you can't start full dose. You have to taper up the dose. Cromolyn, like other drugs we use in the world, can provoke a mast cell activation initially, so you taper up slowly. So it's something I think we talked about in the previous episode. If a patient tells me, I tried cromolyn, it made me feel terrible, you need to say, well, what did you do? Did your doctor start you at 200 3 times a day? Bam, that's why you felt terrible.
Yeah, everyone will feel terrible if you start too high.
Right, you start at a tapering up dose. We probably all have our different tapering schedules. I started about 50 and work our way up. So that's pearl 1. Pearl 2, in commercial, comes in these disgusting, crappy plastic vials. And each manufacturer has a different plastic vial. And I can't tell you how many times I've had patient get brand A, really working great, doc. Went for my refill and was given brand B, didn't know that. And all of a sudden, it's making me sick as hell.
Yeah.
All my MCAS symptoms are back. What's the difference? Oh, go back and check. And they have 2 different brands. This one's plastic is leaching into the cromolyn, and this one's not. If you find a commercial brand, this is to you, the patients. If you find a commercial brand, don't let the pharmacy change it when you renew it. Find one that works. Okay.
Oh, I agree.
Yeah.
That happens a lot with generic meds.
Yes.
Yeah.
Okay.
Right. So anyway, that's a whole conversation on
medicine. You say
medicine.
ketotifen, I say ketotifen.
Yeah. So what is it?
I don't know.
Because
It's
I
tomato,
actually
tomato,
change how I
don't know.
say it all the time when I hear
know.
someone else pronounce it.
I don't know which it is.
Ketotifen.
A lot of these things are like that.
I know.
Yesterday I had a patient who said lumbrokinase. And I said, lumbrokinase? Oh, lumbrokinase. It's like, and I don't know which is the right way.
is one that gets everyone.
Right.
They say it so many different ways.
All right, I'm rambling. Okay, ketotifen. Great mast cell stabilizer.
Love it.
A mild H1 blocker, histamine 1 receptor blocker. Not available in this country as a commercial drug.
Right.
Only,
Has to be
except for an eye
compounded.
drop. Only available as a compounded drug. Okay, not outrageously expensive, but has to be compounded.
Right.
And again, game changer for some patients.
I started 1 milligram twice a day.
Yeah, me too.
Okay.
Usually I start with one once a day just to make sure they're not going to get hungover from it, too tired from it.
Okay. And then how high do you go?
I've gone as high as 10.
Twice a day?
No.
Oh, 5
total.
twice a day.
Total.
Okay. Yeah. Me too.
And sometimes 3 times a day. I'll spread it out. It can make you sleepy like Benadryl.
Yeah. That's why you start. I mean, I always tell them to take their first dose at night, even though I do start them at twice a day, but I have them take their first dose at night just to see how they are the next morning. And I say if they're too tired the next morning, don't take the morning dose.
Just what I do.
Yeah. See, we do the same. We didn't even discuss that.
Right.
That's
we
amazing.
didn't rehearse. Okay, so they are really important. And I know why I don't always start, because I'm doing that blood work. That's why. Okay.
Right. You're doing all the blood work.
And yeah, obviously just from a sort of biologic sense, it makes more sense to use stabilizers than just mediator blockers.
Absolutely.
Okay.
Yeah. Because we don't have blockers for all these mediators.
Right.
Right. So that's also the key.
Well, we can only block 2 mediators.
Right.
Histamine and leukotriene.
That's right. That's right. That's all we can.
2 mediators out of 1,000.
Or prostaglandins. We can reduce
we
the reduction.
can reduce it if the NSAIDs don't cause degranulation.
Exactly.
It's like that's
exactly.
a double-edged sword.
It's a vicious cycle.
So the other I forgot to mention it. The other mediator blocker for leukotrienes is montelukast, also known as Singulair. There's another version of that whose name I can never pronounce, Zarkaflast or something like that.
Zafirculast.
Thank you.
Yeah. Well, I don't know if that's right.
So it's
don't
a
thank
very
me.
good drug.
Yeah.
Especially if there's respiratory symptoms. The problem is it has some pretty significant side effects,
Yes.
Neuropsychiatric side effects.
Right. And we should also say that, some of the interleukins, I mean, there are some really fancy drugs on the market these days, and there are some interleukin that are produced by mast cells that there are specific blockers of those interleukins. But it's not specific to mast cells, of course.
So mast cell stabilizers. So then the other stabilizers out there, let's just both reel them off. Quercetin, okay, can be very effective. Luteolin. Theo Harides loves those plant flavonoids. alpha lipoic acid.
Mm-hmm.
What else?
Those are the only ones I use.
Yeah.
The diet.
Oh yeah, and then my favorite, Benzodiazepines.
Oh right, I was going to say the DAO.
Yeah, that's different.
Okay.
That's different. Let's come back to that. So the other.
I was thinking because we were on supplements.
Yeah.
So that's where I was thinking.
So those supplements can stabilize. I don't find them real powerful.
No.
I try them with everybody.
I will say that what I have found over the last couple of years, quercetin, of course, but if you combine it with which I realize is not a mast cell stabilizer, palmitoyl ethanolamide.
PEA.
Yeah. There's a real synergistic effect that shocked me initially until I confirmed it now about 50 times in 50 patients. There's something where they work together, which has a much more stabilizing effect on the mast cells than I would have ever expected.
And you're giving them as two separate, or is there a combination?
No, there is not a combination. I did know that PEA is more effective in the presence of other kinds of anti-inflammatories. And so just because of my patient population, many of them were already on quercetin. Or quercetin, however you say that one. And I put them on PEA because of other inflammatory responses.
I have to try that.
And
I haven't done that.
All their mast cell symptoms improved exponentially.
Yeah, I have to do
and
that.
I've since done it, like I said, 50 times, and it's a similar response.
Yeah.
So there is a synergy between those two supplements.
Okay.
So I very regularly tell people to take this combination, just so you know.
Yeah, no, I think I'll try it. I have not done that. I used to use PEA a while back for pain, and I didn't think it was so helpful, but I have not done that.
Yeah. So for pain, I don't think it's all that effective, but for any kind of immune response, inflammatory response, it's actually very helpful.
So benzodiazepines.
Yeah.
Let's dip our toe into benzos. So the medical world hates benzos. Doctors hate benzos. This is a real ongoing problem. Benzos are incredibly effective mast cell stabilizing agents. They really quiet them down.
Mm-hmm.
You don't need high doses. The patient does not get addicted to the benzo. The problem is, unless I'm prescribing, I can't find anyone to do it. So if I'm collaborating with a PCP, most of the time they will refuse. They're afraid to give it. It's ridiculous. Okay?
Well, I think, I didn't mean to interrupt you, but
you
part
can
of it...
interrupt me as much as you want.
It's a burden because I think it's, the patients always have to go back to the doctor for the refills. And I think at some point doctors get nervous, like, I've been prescribing this benzo for you now for months. And, I'm getting a little nervous about where you're going with this, even though the dosing is not necessarily being increased and they're not changing the frequency. So the SIG is exactly the same.
And honestly, why does the patient have to go back?
Right.
I mean, I understand all the medical legal stuff,
Yeah.
but it's the tail wagging the dog in our profession.
Because nobody wants to give 12 refills of benzodiazepine.
So don't. I give it for benzos. I don't do that.
Neither do
But
I.
But if I get feedback, I'll continue to refill. I'm not going to make
Absolutely.
a poor patient come in every month. First of all, it's not fair cost.
Well, as you know, a lot of PCP's office are now going to this thing where you need an appointment for refills, especially for controlled substances.
Right.
So I think that's become problematic because oftentimes, patients can't make an appointment.
No, I don't blame the patient. I mean, I think they're right.
I agree with you. I think
it's a ridiculous solution to a problem that basically the feds, the regulations have created. Anyhow, so the doses are very low. So as an example, lorazepam, Ativan, comes in a 0.5 and a 1 milligram, and I think a 2 milligram dose. Okay, most other physicians will prescribe 0.5 or 1 milligram. These patients will respond to 0.25 once, twice, 3 times a day. Mm-hmm. It's still a dose that's very, very low. And it can be incredibly effective.
And to me, I almost liken it to low-dose naltrexone.
Yes.
Because it just, that
Very
low
good
of a
point.
dose, it just engages the receptor just enough where I don't think it actually induces tolerance and addiction, which is always everyone's big fear, right? Because I have not had patients that need to go up on their dose for the same effect.
Nor have I had
which
people,
is the definition of tolerance and addiction, right? So.
Nor have I had people, when we stop it for some reason, have any withdrawal.
Exactly.
Okay.
So,
really a great drug.
Yeah,
great class of drug.
I agree. And, I always tell patients, like, neurologists are very comfortable with benzodiazepines. We use it for a lot of things.
Yeah.
We've used it forever for seizures, for headaches, for lots of disorders. So I have a great comfort level using benzodiazepines, and I don't mind using them at all. And I use them, as you say, very, very tiny dosages for the mast cell patients, and it really does wonders for them, to the point where sometimes I'm thinking I'm just not going to even do anything else other than just let's put you on benzos for now, because usually a lot of other symptoms that I think would respond to the benzos. So I just often start it. But some patients themselves are afraid That, you
Oh,
you
yeah.
bring up
I
like
have a lot of
Ativan or
patients that
Xanax
they
or
won't take it.
Valium. I
They're
know.
more than afraid. They
I know.
refuse.
Yeah.
It's,
There's a weird stigma that's associated.
yeah. Yeah.
But I almost feel like those mast cell symptoms in some respect, and maybe not exactly the same, but sort of what we were saying at the last episode on pain, where pain begets pain. We were talking about that. I really feel if you don't get these mast cell symptoms under control, you're sort of letting, the horse run down the field, and then it's going to be really hard to get it back in the barn.
Right. And probably back to Ben, as part of the benzo story, I think you were just saying this, that not only do they stabilize mast cells, and by stabilize we mean they don't degranulate, they don't explode. Okay?
Right.
The benzos also address some of the other things that trigger mast cells, such as pain and spasm.
That's right.
So if you think about it, you can't get a better drug.
No, I know. It's a great drug.
Right.
It really is.
So let's finish.
And just one added thing, just speaking about the mediators, because there was a great question on our Patreon page. Again, we love our Patreon page, so go ask all the questions you want.
Yes.
But regarding, so they have these 1,000 mediators. Do they always release everything? And so we should say that, we're not going to go into the physiology of mast cells, though I suppose in another episode we could. But there are preformed mediators, and then there are those that we refer to as de novo synthesis, which means when they are needed, the mast cells have the ability to make them, to synthesize them, and then they're released.
Right.
So when a mast cell is working properly, it just releases what it needs to at that moment in time. And it might be something that's already preformed that it might need to make and synthesize another mediator. But when you have mast cell hyperactivity, all bets are off. Right. So not that it's releasing 1,000 mediators at the exact same time all the time, but it's likely disproportionately and or inappropriately releasing mediators that it shouldn't be releasing.
Yeah, when I explain it, I probably get a little melodramatic. I basically say the mediators, the mast cells explode. They explode and they release all these
Maybe that's
mediators.
more accurate, actually. I like to believe, as I said, I have a respect for physiology. I like to believe that there's some control.
No, there is, but I want to make a point.
But I do agree that it's wayward. It's just it's off the charts, right? It's not they're not behaving appropriately. Let's just put it that way. So they're releasing things they shouldn't be releasing. They're certainly releasing them in concentrations that are inappropriate and disproportionate.
And I still want to get back to drugs, but since we're talking about
I just need to insert that because I thought of that question that someone asked.
I want to go back to something you said earlier and related to the 1,000 molecules. And key to the whole septad concept, the whole interconnected concept, these mediators that are released can basically injure, damage, chew up connective tissue.
Yes.
Okay? So it's such a key concept to understand in terms of why does patient A go on to develop CCI and patient B doesn't.
Well, I do believe that the mast cells are one of those common denominators in that septad.
That's
I think,
yeah.
So not only the connective tissue, that was my point. I think even with the dysautonomia, the small fiber neuropathy, all the autoimmunity, definitely the autoimmunity, obviously, because we talk about the innate and the adaptive immune system and its interconnection, all of the gut stuff, so it is one of those very strong, very important and critical denominators amongst all the septad diagnoses, even though it's its own diagnosis of the septad.
But it's why it's a priority diagnosis and a priority management.
And deserves a lot of time.
Right. So I want to just finish more drug stuff and then go to DAO. Okay. And I don't care how long this runs.
Okay.
All right.
Wow.
So we've done a lot of the oral
hours.
stuff. Okay. What do you do when the stabilizers fail or are not doing enough? So there's a class of drugs called tyrosine kinase inhibitors, TKIs. Imatinib is the major one that we all know, that we're most familiar with. Imatinib is a chemotherapy drug. Mm-hmm. It's used to treat gastric tumors called GIST tumors. And I try to describe it to patients as you have blockers, you have stabilizers, and then you have this class of drugs which just turns the switch off on the mast cell. Sounds great. Why don't we always start with imatinib? Because I don't find it works very well.
I haven't found it works.
I've been so frustrated.
I haven't prescribed it actually in months.
It's just so frustrating because it should have been the be-all, end-all drug.
But that just proves that we don't know enough about these mast cells.
Exactly. So there's imatinib and then there's a bunch of new ones, but I'm not real hopeful about them, I have to say.
Right. Honestly, yeah, you're absolutely right. I haven't found those more aggressive drugs worth the toxicity and the side effect profiles that they have because I have not seen them be beneficial to patients. So I've got, when I got the stabilizers on board and I do a lot of prescribed antihistamines. Like I love ciproheptadine.
Yes. I didn't mention
Oh my God. I love that drug.
And then
for patients.
Rupatadine from Canada.
Absolutely.
Yeah. Cyproheptadine is great.
And I even think about how in children, we use cyproheptadine for migraines in children. We use cyproheptadine for cyclical vomiting syndrome in children. And I'm thinking, I'm just treating their mast cells. Again, it's going back to how we started this episode.
Lenny Weinstock on our masterminds, he's a gastroenterologist. He had a post recently that it helps, obviously, mast cell histamine 1 receptor blocker, but it helps with gastroparesis. And what the hell was the third one? Maybe brain fog. I can't remember, but it was a really potent drug.
It definitely
which is
improves
ironic.
brain
It's
fog.
one of the oldest H1s on the world.
I know, and in fact, I always tell my adult patients, I've got like 5-year-olds on this drug, and that makes them feel better, right? Because everyone's always like, "What are the side effects?" Because of course, mast cell patients are very often hypersensitive to medications. They have a long history of they took this drug, they got a rash.
Right.
They took this drug, they felt nauseous. They took this drug, So they're often very concerned about the side effects of drugs, as they should be. Everyone should be when you take a new medication. So I tell them I've got 5-year-olds on dosages higher than you,
Right.
and that makes them feel better. And it is true. When I think about all the things that we use cyproheptadine for in the pediatric neurology world, I think about I'm just treating their mast cells, and that's what's probably underlying this diagnosis, which again goes back to how we started this episode, which is all these diseases and symptoms and diagnoses that we just sort of, we're not recognizing the role of the mast cells enough. And I think it gives treatment options. But regardless, I love cyproheptadine, and I prescribe that quite a bit for my patients.
So ropatadine is sort of the new guy on the block. I don't know a lot. I'm suggesting it now, but I don't know. I haven't had enough experience with it.
Right.
But I think its claim to fame is that it isn't only a histamine 1 blocker. It has activity with platelets to decrease platelet aggregation and platelet release of other chemicals. But I think we have to see how it plays out.
Is it available?
No, you have to get it from Canada.
Usually you have to order it, right?
So let's talk briefly. Everything we say briefly, talking here. So what do I do when I'm still failing?
I throw steroids at it.
I don't. Well, occasionally I will, but not much.
Oh, I do all the time.
But I want to describe the IV mast cell protocol.
Okay. Oh, okay.
Okay.
I do that, but patients have to come into the clinic for that. So.
No, I get it done at home.
Oh, you do?
Yeah. So again, thanks to Andy Maxwell, who
how do you get
initially
it done
suggested
at home?
this.
Unless they have home nursing. I mean, how do they get it?
They have a PICC line in,
but not every patient has access.
Well, let me tell you how I do it. Okay.
Tell us. I'm now with our subscribers. Tell us, Dr. Kaufman.
So these are treatment-resistant patients,
right?
Okay, who may be resistant partly because of all the excipients, garbage, junk, crap,
right,
added to all the pills that our pharmaceutical companies make. Okay, and we should come back to that statement in a minute. The beauty of IV drugs is that they generally have no excipients. And if you order preservative-free, theoretically they have nothing but the active molecule and hopefully in a glass bottle.
Right.
Okay. So the IV meds are generally IV lorazepam, the game-changing drug.
Love
game-changing drug. I cannot tell you how much. IV Benadryl, IV Toradol, which is thought of as a painkiller. It's in the NSAID family. And IV Zofran and IV famotidine. Okay, so it's a lot of drugs with a liter of saline. And there's a whole protocol of how to give it, which I won't go into. And it's given, I generally we'll start a treatment-resistant patient on this once or twice a week and see what they say. And almost without fail, I mean, I literally think I have one patient that just didn't help. They will say, I am so much better for 48 hours, and then it starts to get worse again. And so I'll amp it up to 3 times a week. And for a while, you can just do a new peripheral IV each time. You don't have to have a PICC line placed. And I'll often say to the patient, this must be so difficult for you. Maybe we should try something else. And they'll say, no, this is the only way I get to live. And they want to just keep doing it. Give me a PICC line. I'll take anything. I want to keep doing this. Theoretically, and hopefully it quiets everything down and you can stop doing it, or you can treat the underlying infection, which I think is often the cause. But for patients, it's life-saving. Literally, I'm not being melodramatic, life-saving for these patients.
No, 100% agree. When I do it in the clinic for them, remarkable response, like 100% better. I mean, I'm not kidding. They come in all sick and flaring from their mast cells. They leave completely feeling fine. And in fact, very often I'll hear that they were able to eat that night a dinner that they hadn't eaten before in terms of the choice of foods. They can tolerate those foods. Yeah, it is incredible. I have not gone as far as as getting a PICC line placed specifically so they can get it at home.
Right. But so I do the PICC line, but I'll say
that
with
the difference in your
IV.
patient population, I think, in some respects, although there's a lot of overlap, obviously, is that you do a lot of infection treatment, right? So you have PICC lines and...
No, but I don't have that many PICC lines. This is done peripheral IV mostly, unless it needs to be long-term.
Right. So you get home nursing to come in.
Yeah, we get home nursing.
Okay.
We actually, most of the time, somehow get insurance approval. I don't know how.
See, that's what I never thought I could get. I don't see.
It's easier to
you
get
send
that
me all the
approved
IVIG patients to get approval, and now I'm going to start sending you all these mast cell patients.
And the biggest problem I usually have is the nursing companies, the infusion companies, can say, "What the hell is a mast cell protocol? I can't."
That's exactly what I would expect to happen, which is why I haven't even broached the topic with home nursing.
It's been working out.
That's fantastic. I'm so excited about this.
Yeah, the problem has been the Ativan. They don't like to give lorazepam. They say, "Oh, I can't get IV lorazepam."
Well, first of all, it's out of stock.
That too.
It's not even
anyhow. So
any
I guess the message is
purple carrot juice.
The IV mast cell protocol can be a true game-changing intervention. Okay, let's go to DAO.
Go.
Okay.
I want to hear all about DAO.
Well, I don't know.
I don't recommend it as often as
so
others
I didn't
seem
either,
to.
but I've learned some lessons here. So there's histamine intolerance and there's mast cell activation syndrome. And not everybody will agree with what I'm saying. This is how I conceptualize it. So we've already talked about MCAS ad nauseum. I think people understand what we're saying. Histamine intolerance to me means you eat food. Food has histamine. Some foods have more histamine than other foods. Leftovers have the highest amount of histamine. And you don't have an adequate level of diamine oxidase, DAO, in your gut. That is the enzyme that metabolizes histamine. If you don't have enough when you eat that histamine food, you absorb that histamine. It gets absorbed. I don't know what the right word is. And that adds to your mast cell activation syndrome. So you have patients who have MCAS, you have patients who have histamine intolerance, and you have patients who have both together. Okay? I believe there's one lab in the entire world that measures DAO levels.
What lab is that?
It's got a funny name that I learned from Larry. I can't. It's got a funny name. I don't bother. I just try DAO.
Yeah.
See if it works. Take DAO 10 minutes, 20 minutes before your meals. If you feel better, you have DAO deficiency, and take DAO. And for some patients, it's incredible. And I didn't used to. It's something I've learned more recently, and I often forget it still because I'm so hung up on the mast cell drugs. So everybody, talk to your doc. DAO. You don't need a doc. You can order it online.
Yeah. No, absolutely. I mean, I don't recommend it nearly as often as I probably should, because I haven't seen it be all that much of a game changer for patients. And also, when it comes to taking a lot of supplements, I'd rather go with the meds first and foremost, because I think they're more effective, they're more potent, they're more rapidly acting. And the problem when patients have been so sick for so long and can't even eat a regular diet where they can get all of their appropriate nutrients, to wait for supplements to sort of take a hold and be of any effectiveness or efficacy, then I think it's making the patient suffer needlessly. So I just like to go for the meds. I do a lot of IVIG. IVIG, as you know. I usually do it obviously for other indications in the Septad patient, but I will say their mast cell symptoms very much improve. Now, first, when you start it could provoke mast cell activation.
Oh, yeah.
I have a lot of patients that after their first infusion or even their second infusion, or sometimes even their third infusion, though by then it's starting to get better, have severe mast cell flares. And I even wonder if it's behind all the side effects that we know about IVIG before we were even talking about mast cell activation syndrome, right? So, and that's why the pre-med protocol is Benadryl and steroids and Zofran, which by the way is another favorite drug. So I had mentioned that I love ciproheptadine. I also like Zofran. I find that there's an autonomic component to a lot of the mast cell activity. And so I find Zofran to be very effective at also improving mast cell symptoms. But regardless, so the IVIG over time helps mast cell activation syndrome symptoms as well. And so that's another exciting thing. So if you can find the indication to get IVIG approved, then you can treat mast cell with IVIG.
Right.
So that's a nice thing. And the other thing, of course, is that apheresis. So now that I, do it in the clinic, we know that the apheresis removes a lot of those mast cell mediators. And so one of the things that I've often thought about is that, a lot of these medications that we use and the supplements and the things that we do, it's not removing these mediators fast enough in large enough quantities. And I think that there's just like this perpetual inflammatory kind of response
the sink
going on.
is always being filled.
The sink is always being filled. You're really good at analogies. I'm really bad at it. So I find with apheresis, we remove the crud, right? All that stuff that's just sort of been around for some patients like decades, if not years and months. But and it just sort of like provides a clean slate where those medications seem to be way more effective at lower dosages. So I've been able to reduce the dosages of the medications after a couple of rounds of apheresis on some of these very severely ill patients with mast cell activation syndrome. So that's another exciting treatment. Again, these are not easy treatments. They're obviously not cheap.
Right.
They require coming into clinic and sitting in a chair for a couple hours, but remarkably effective.
Yeah. So let me throw one other in there. Exosomes? I don't want to spend a lot of time on this because I know we keep going over here, and I have something else I also want to talk about. But since you brought up apheresis and IVIG. So exosomes are acellular packets of signaling molecules and RNA building protein molecules, okay? And I've seen it be very helpful in patients with significant POTS and autoimmune disease, antibody disease, et cetera, like that. And I was not sure about mast cell, okay? And I gave it to a patient that I've taken care of for over 10 years. The most intractable patient, intractable MCAS, she can only eat once a day, only eat a few foods. And I said, I don't know what else to do. Let's just try it. It's expensive, but it's totally off limits to do. Let's just try it. This patient is suddenly able to eat.
Yeah.
One infusion. She's had one infusion in 7 or 8 months. She's able to eat her more than one meal a day without, I can't tell you, I mean, she would eat nothing all day long, come home at night, 6 o'clock, and take Ativan and Benadryl and famotidine and a couple of other mast cell drugs, and then she could finally eat and still react.
Right.
So that's out there.
And I have the same experience with autologous stem cells.
Right.
Same exact response.
And one of the reasons is, what are stem cells delivering? They're delivering exosomes.
Exosomes, right. Because you're right, because such a rapid response, it can't be the stem cells.
Exactly.
Yeah.
Okay.
And just one other pearl that I thought of that I also do that is not hard to do at all. In fact, over the counter, you can do it if you want. Lidocaine patches are
you mentioned this the other day.
Incredible. Like, so you can prescribe, of course, the 5%, but you can buy the 4% just over the counter. You don't need the 5%. In fact, I haven't seen a difference on the Salon Pas. In fact, my daughter likes to say that I think Salon Pas can fix everything because I'm always suggesting them. But I've had a ton of patients who have had it's a reaction. So it's not like for the chronic mast cell kind of patient. It's for the flare, the reaction.
But it makes sense. What they're responding to is a decrease in pain.
That's exactly right.
And pain triggers mast cells.
I was just going to say that. That's exactly. You took
Back
the words out
Septad,
of my mouth.
I'm sorry.
I know. Don't be sorry.
But it's just so important to connect everything.
But how easy is that?
Right.
I say, go buy a box of Salon Pas.
Right. So,
I don't mean to mention a brand. The Salon Pas doesn't pay me anything. But a lidocaine patch is my point. It's easy and cheap and very effective when you have like a flare of something.
Right.
So that's just another pearl that I'll throw out there.
It's important though, because it's an example of why the care of these patients is so complicated, because you got to manage the pain to decrease the MCAS. You got to manage the SIBO and the leaky gut, because that crap from the leaky gut kicks off mast cells.
Right.
Okay, real fast.
Which is why we use the word complex again, right? So I know we're all over.
But this is so important. So I don't know if we'll end with this, but I still want to say it as an ending. We went through all these drugs and everything, okay? I can't emphasize enough how much this treatment, as is true for so many other things we do, is trial and error. If you try Claritin and it doesn't work, then you try Allegra. And if Allegra doesn't work, you try Zyzal. And if Zyzal doesn't work, go to a different brand, go to a different generic, because one generic may have excipients that are making you sick and the next won't. It's sort of a detective nightmare, okay? You can't tell which one's going to have junk in it, so you can't rule out the molecule. You have to rule out the product, okay? So that requires a lot of patience on the part of the patient and the physician, and a recognition and acceptance this is trial and error of these different products.
good point to end on. It's actually an excellent point. Yeah, you just can't decide that these antihistamines don't work, right? No throwing the baby out with the bathwater.
And I'm sure in this very long episode we've forgotten some things.
Oh, we'll go back to it. We'll do another episode.
But I think the message here is how critically important this mast cell activation syndrome is to our patients and to patients with complex illness, and how challenging it is, but equally critically important that we get control so we can prevent connective tissue.
I do think a good episode would be to go through the mediators at one point, or at least the most common ones that are the ones at play for the symptoms. I think that our listeners would be interested.
Right. I mean, there's things we haven't touched on.
I know.
As today, I was masterminding emailing, and there was a whole discussion about estrogen.
Yes.
And the flares
I want to
that
talk about
female
estrogen.
patients experienced, in their cycles.
Estrogen is a great topic for a podcast because there are pros and cons, right?
Right. So
and neither one of us are female hormone experts, but we're going to take it on anyway.
Yeah,
we're just going to have our usual conversation of us just pontificating.
Or sounding stupid.
Hopefully we won't sound stupid. Thanks for joining us.
Thank you.
Thanks for being a subscriber. Ask us questions, share this podcast with everyone you know, and we'll see you soon. Bye.